Good evening, everyone. So hope I'm audible. Can anyone confirm? Hello, can you hear me?
Yes,
Hello.
sir, you're audible.
Thank you so much for confirmation. Okay, so good evening, everyone. So today we are here for a MPS webinar on new targets for anti-cancer drugs. So we have another 5-6 minutes. Just let me say a few words about Medical Pharmacologist Society. Hope all of you know about our society already. We are a medical pharmacologist society, majorly catering for MD pharmacologists, and they will be eligible as life members. And we also support other pharmacologists and other healthcare providers too by providing best available opportunities. They may not become life members, but if they continue to contribute to MPS society, so we will honor them with the honorary membership, which is valid for limited period. Based on their continued contribution, we'll continue to renew their honorary membership with us. For this honorary membership, the other than MD pharmacologists need not pay anything. They just have to serve the society, and even though they will not be able to regulate the activities of MPS, but they will be able to contribute to the field of medical pharmacology, and mutually they can get the benefit from us also. They can participate and avail the facilities that we offer for MD pharmacologists other than life membership. So this is in brief about us. So when did we start? MPS Society was started in 2000, not 19, it is 2016. And so far we have conducted major conferences, MPS NCTS program, which was around 400 people participated. It was a big success. Majorly, we wanted to start with a good clinical practice workshop, but it turned out to be a major conference, and where we had so many participants and the speakers. And we ended up releasing a book called Clinical Trials Management. All the speakers, they all contributed to writes by contributed by writing chapters, and then finally it became a book, and it is more than around 500 copies are already sold, and it is very helpful compendium for all those who are interested in learning about clinical trials, clinical research management, and majorly clinical trial documentation, and also the uh, product, like investigational product management, ethics committee management, like ICF, writing ICF, investigator responsibility, sponsors responsibility, like this. Various chapters are there, and it's a very quick review, book, where anyone who is going for any interviews to any pharma company or clinical research organization, they can easily use this book for reference, and they can easily learn from this. In addition to it, last year we conducted MPS Con 2024 at Savita Medical College, Chennai. There we ventured into another important milestone, that is Crucial Pharmacology Trends book series. We introduced already 2 volumes, so totally 61 chapters written by more than 100 authors coming from various parts of India, and they all proudly speak about our book. and they all spread very good news and views about crucial pharmacology trends, and it is mainly targeted for postgraduate postgraduate pharmacology exam success. So all the postgraduate students who are aiming for getting good, who are aiming for good output in their examination, and I'm sure they will be able to take the benefit of this book, Crucial Pharmacology Trends. They are available in Notion Press website, also available in Amazon, Flipkart, and all the major online sales sites. So you can easily order and it will get delivered to your home. And all these chapters are written by MD pharmacologists and the PhD holders, and they are really very helpful books available and for easy reference. So I suggest all the MD pharmacologists, students, staff, faculty, and even the budding pharmacologists from various streams, they can take the advantage of these books. And in addition, this year we conducted a very interesting program, that's a conference at uh, AIMS Guwahati, and it's even those days are still ringing in my eyes and ears. They are really highly memorable days. I'm very happy uh, the way it was conducted and the way it was received by everyone. And in addition to this, we have already started working on Crucial Pharmacology Trends, Volume 3, 4, most probably fifth one also. More than 112 chapters are accepted by various authors to write and submit. So already we have received more than 50% of chapters, and remaining are going to come. And we have already started editing of this book, Crucial Pharmacology Trends, Volume 4, 3, and 4, and most probably fifth one also. And we will be happy to present these books to all the medical pharmacologists and postgraduate students of various streams who are interested to learn about various topics that are written in these books. So with this, I would like to appreciate the enthusiasm of all the pharmacologists. They are joining hands and really appreciating our efforts. I can say that more than 300 copies of Crucial Pharmacology Trends books are already sold. So this is something which is we are trying to change the way how the pharmacology is taught, how the pharmacology is learned, and how it is disseminated. And please be part of this journey. Looking forward for more interesting days to come on the way along with MPS, Medical Pharmacology Society. Looking forward for all of you to meet at CD Cymer, Bangalore. Now it is called as Bangalore. So we are very fortunate that Ramnagara is integrated to Bangalore. So in that way, CD Cymer is coming under the Bangalore South district, and we will be hosting the next conference, MPS Con 2026, and I look forward to see all of you here. And now we just reached the time, so let me just start with the program. So let me introduce our today's speaker, Dr. Sapna Patil. Can you see my screen? Can anyone confirm? Can you see my screen? Dr. Sapna, can you confirm?
Yes, sir.
Okay, thank you so much. Yeah, so welcome everyone. Today we are going to discuss a very interesting topic related to cancer chemotherapy. Okay, okay, no problem. So let us start. Okay, so Dr. Sapna Patil is our today's distinguished speaker. She is currently working as Professor, Department of Pharmacology, Saptagiri Institute of Medical Sciences and Research Center. And I would like to also tell you that she is also our board member also. She is associated with our society since the beginning. So as a respect to that, she's been working with us as the board member also. She completed her MBS from Kempegoda Institution of Medical Sciences, Bangalore, and MD from Sri Devaraj Aras Medical College, Kolar. So she has also done various additional diplomas and degrees like PG, D, MLE, CCE, BDM, that is related to diabetes mellitus course, clinical research course, pharmacovigilance course, offered by various institutions. And she has more than 18 years of teaching experience as a clinical pharmacologist. And also, she worked at Apollo Hospitals, Karnataka division as the clinical pharmacologist. Her main area of interest is teaching, clinical research, and pharmacovigilance. She has participated in many international and national conferences, CMEs, and workshops. She has presented papers at various conferences, including international conference at Malaysia. So, Malaysian Society of Pharmacology and Physiology. She published articles in various national and international journals also. She is a well-respected life member of various professional bodies, including Indian Pharmacology Society, APPI, MPS Society, KSMP Society, and so on. She is also a reviewer of various journals and also chairperson and judge of various competitions. Now, I would like to request Dr. Sapna Patil to take over the stage and start the presentation.
Good evening to one and all. Am I audible?
Yes, yes, you are audible.
Thank you very much, Dr. Shivamurthy sir, for the kind introduction and also for giving me this opportunity to present my topic today. I shall share the slides.
Yes, please.
Yes. So today I'll be discussing about various new targets for anti-cancer drugs.
Hello?
Hello?
Yeah, we can hear you. Can you change are you able to change the slides?
No, sir.
Just,
No, I'm not able to change.
okay, you can close again.
Yes.
You can stop the sharing. Okay, click on share screen. After that, select the screen and then click share and then make the power like slide more
Right.
slide share mode. Yeah, that's the I would say the slideshow mode. You are on the slideshow mode.
Yes, sir.
Okay, now you try sharing and changing the slide.
Yes.
Yeah, it is moving. Yeah.
Okay.
Okay, yeah, you can come to first line and then you can start.
So as I've just told, I'll be discussing about the new targets for anti-cancer drugs. This is the outline of my talk, starting with the various cancer treatment modalities and the role of cell cycle kinetics and the anti-cancer effects, cancer evolution and drug discovery, role of combination chemotherapy, and also about drug resistance, and of course about all the new targets which are being used for as anti-cancers, artificial intelligence and its role in cancer identification and drug discovery, and also a few points about cancer vaccines, and finally the conclusion. So these are all the various drugs which are available for treatment of various types of cancers. So to give a brief introduction to this topic, we all know that cancer is a process of uncontrolled cell proliferation. Initially, it will start as a local disease, but later on, it can spread to other organs and it can lead to metastasis. And it is one of the most fatal diseases in recent times. And cancer has killed many lives every year. Now, cancer pharmacology has changed dramatically during the recent past. There is improved understanding of cancer biology, and that's why the discovery of various types of newer drugs. Now, despite the major therapeutic success in cancer treatment, some of the drugs, or maybe I can say most of the drugs, have narrow therapeutic index and they have the potential to cause harmful effects. And hence, we should have thorough knowledge not only about the mechanism of action, but also the pharmacokinetic properties, various drug-drug interactions, and of course the adverse effects. Some of the anti-cancer drugs are also used in a variety of non-malignant diseases also. The best example would be that of methotrexate, which is mainly used in the treatment of cancers, but also it has off-label use in certain diseases like rheumatoid arthritis, organ transplantation, and even psoriasis. Now, what are the two main types of cancer treatment modalities? One is primary chemotherapy. The second one is what is called neoadjuvant chemotherapy. So, primary chemotherapy mainly it is helpful in the treatment of advanced stages of cancers, and neoadjuvant chemotherapy mainly for local tumors and which have other modalities of treatment like surgery and radiation, and also combination chemotherapy is used nowadays. This is the cell cycle where the drugs act at various phases of the cell cycle. So, for example, S phase specific drugs like hydroxyurea or cytosine, S phase specific drugs like methotrexate, while M phase specific drugs are vincristine, vinblastine, and paclitaxel. Certain drugs they are cell cycle non-specific, like the alkylating agents, antibiotics, cisplatin, and so on. Now, to briefly tell about the cancer evolution and drug discovery. So, the discovery of cancer-specific drug targets, mainly the growth factor receptors, epigenetic processes, tumor vascularity, and cell death pathways and immune escape mechanisms, they have evolved over the years in the treatment of cancers. And human malignancies are highly diverse group of diseases. So, the targeted drugs are helping to overcome the resistance. And not only that, in the treatment of various types of cancers, mostly it is the combination therapy which is used, and very rarely only monotherapy. And combination of these cytotoxic drugs, they can induce tumor cell death, and they can also help in the response to immune checkpoint inhibitors. Now, this is the graph where time is plotted on the x-axis and on the y-axis number of cancer cells, that is log scale. So, in the top portion of this graph, it shows how the treatment for various types of cancers, it is with infrequent time limits, and these are the cancer cases where it can lead to metastasis. And although there is symptomatic, treatment which is given. While in the middle portion, it shows or it depicts the cancer treatment for local tumors, and sometimes it can also lead to complete cure. While in the uh, bottom portion of this graph, it mainly uh, tells us about combination chemotherapy and for various types of advanced cases of cancers. What is the role of combination chemotherapy? So it helps in guiding the selection of various drugs. So based on their efficacy and potency, toxicity, mainly we have to weigh the risk-benefit ratio of the adverse effects which are produced by these anti-cancer drugs. There should also be optimum scheduling. That means the chemotherapy cycle should be shortened with chemotherapy-free intervals should be less. And of course, mechanism of drug interactions is an important point to consider, because we are using more than 3-4 drugs in the combination chemotherapy. So we should be aware of the drug interactions also. And also avoidance of arbitrary dose changes. The dose intensity, like I have said already, that the dose escalation should be done in a slow manner, and it should be started with a low dose, and maybe the dose can be escalated little later. And dose-free intervals in between the um, chemotherapy cycle should be shortened. And this kind of combination therapy will also help to avoid drug resistance, which is the major problem with these drugs. So coming to the some of the older anti-cancer drugs, like the non-classic alkylating agents, namely procarbazine, dacarbazine, and bendamustine, platinum analogs like cisplatin and oxaliplatin, anti-metabolites or folic acid analogs, methotrexate, pemetrexate, and so on. So coming first to procarbazine, the main use is in Hodgkin's lymphoma and gliomas, but the adverse effect, it has greater capacity for mutagenesis and uh, carcinogenesis. The next drug, dacarbazine. So this can be used in Hodgkin's lymphoma, soft tissue sarcomas, and melanoma. And the route of administration is intravenous. So main side effects, it can produce GI-related side effects, neurotoxicity, hepatotoxicity, and in certain group of patients, it can also cause allergic reactions. Next, coming to the platinum compounds or complexes, which form covalent metal adducts with DNA. So in this group, cisplatin is almost like a is the main drug. So main use is in testicular, ovarian, bladder, head and neck cancers, and breast cancer also. This drug, again, it has to be used intravenously. Major side effect being nephrotoxicity. So this toxicity can be reduced by what is known as forced hydration. That is, before starting the treatment with cisplatin, diuresis and use of another substance known as amifostine. Other than nephrotoxicity, it can also lead to ototoxicity and GI-related symptoms, for which the antidote, or it can be treated with aprepitant, which is an NK cell inhibitor. Other than these side effects, there is also peripheral sensory and motor neuropathy. Coming to carboplatin, so the main indications are in testicular, ovarian, bladder, anal, head and neck cancers. So compared to the other drug, it has less chances of causing GI-related side effects, neuro and ototoxicity compared to cisplatin. The dose-limited toxicity being myelosuppression, and some of the patients also, I mean, there could be hypersensitivity reactions. The other drug in this group being oxaliplatin. So this is mainly used in the treatment of colorectal, gastric, and pancreatic cancers. So again, this drug also can cause peripheral neuropathy. Next, coming to the anti-metabolites. So main drug in this group is methotrexate. So this drug acts by inhibiting dihydrofolate reductase. It can be used in the treatment of choriocarcinoma. In this condition, it is believed that methotrexate almost it gives 100% cure, and other diseases, other cancers being breast cancer, head and neck cancer, and lung cancers also. And as I've already discussed, it has non-cancer uses mainly in psoriasis, rheumatoid arthritis, and even organ transplantation. So the route of administration could be either oral, intravenous, or intramuscular. The major limiting factor is myelosuppression. So what we have to do is, before administering methotrexate, especially if high doses is required, a substance known as leucovorin rescue, it is called, that can reverse the toxic effects. Other than that, glucarpidase, which is a methotrexate cleaving enzyme, so this also is approved for treating the toxicity. Another analog or newer analog of methotrexate is pemetrexate, which is used in the treatment of mesotheliomas and lung cancer. And one shortcoming or disadvantage of pemetrexate is it can lead to folate and vitamin B12 deficiency. Hence, just like leucovorin rescue therapy with methotrexate, with pemetrexate, again, we can give folate and vitamin B12 supplementation. Coming to the other drugs known as natural plant products. So under this, we have vinca alkaloids, mainly vinblastin, vinorelbin, vincristine, and eribulin. So vinblastin and all the other vinca alkaloids, they inhibit tubulin polymerization and microtubule formation. So vinblastin is used in both the types of lymphomas, breast cancer, testicular cancer, and it is part of ABVD combination with doxorubicin, which I'll be discussing little later. Now, coming to the route of administration, it has to be given intravenously, and extravasation can cause irritation and ulceration. And we need to reduce the dose in patients with impaired renal function. And it is the alkaloid which is least neurotoxic. Other than that, this drug can cause GI-related side effects also. The next drug in this group is vinorelbin. So this can be used in breast cancer and non-small cell lung cancer. So since intravenous administration needs to be done, again, we have to keep in mind about extravasation which can occur. And we need to reduce the dose in patients with impaired renal function. And in some patients, they also have myelosuppressive action, mainly granulocytopenia. Coming to the next drug, which is vincristine. So main use is in acute lymphocytic leukemia, Wilms tumor, Hodgkin's and non-Hodgkin's lymphoma. And this drug is part of the regimen known as CHOP regimen, which consists of cyclophosphamide, doxorubicin, vincristine, and prednisolone. So this has to be administered intravenously. And we need to reduce the dose in patients with liver dysfunction and renal impairment also. The dose limiting toxicity is mainly neurotoxicity, and it is better tolerated by children than adults. Another drug in this group is eribulin. So main uses or indications are breast cancer and liposarcoma. So side effects mainly are similar to the other drugs in this group. Coming to the next group of drugs, taxanes and other antimicrotubule drugs. So the drugs here are paclitaxel and estramustin, epipodophylotoxins such as etoposide, temiposide, camptothecin analogs like topotecan and irinotecan. So coming to these taxanes, which stabilize the microtubules and inhibit depolymerization. So paclitaxel main indications are ovarian cancer, breast cancer, prostate, and head and neck cancer. So again, this has to be administered intravenously. So we need to reduce the dose in patients with hepatic dysfunction. It is a substrate of P-glycoprotein efflux count. So there could be some amount of drug interactions with other drugs. And also it has a tendency to cause myelosuppression. peripheral neuropathy, and mucositis. So the next drug is docetaxel, which is mainly used in ovarian, breast, lung, head and neck cancers and bladder cancers. So there's no effect on doxorubicin clearance, and the pharmacokinetic properties are almost similar to paclitaxel, except that docetaxel causes decreased or less chances of neutropenia and neuropathy. Then we have the camptothecins, which mainly inhibit topoisomerase 1, and there is accumulation of the single strand breaks. So the main drugs in this group are topotecan, mainly used in treatment of ovarian cancer and small cell lung cancer. So the route of administration is mainly intravenous and even oral administration. So again, this drug can cause neutropenia, other GI related side effects, and we need to reduce the dose in patients with renal dysfunction. Irinotecan used in the treatment of colorectal cancer and small cell lung cancer. And this drug is part of the folfiri or folfirinox combination, which is used for gastrointestinal tumors. So this is irinotecan is actually a pro-drug which gets later activated, and it has to be given intravenously. So again, some of the side effects like diarrhea and neutropenia can occur, and acetylcholinesterase inhibition mainly results in cholinergic syndrome. So we can treat with atropine. Then next, coming to the coming to the anti-tumor antibiotics, mainly actinomycin and anthracyclines such as doxorubicin, daunorubicin, and epirubicin. So dactinomycin, which is also known as actinomycin D. So main use is in Wilms tumor, rhabdomyosarcoma, Ewing's and Kaposi's and other sarcomas, and also it has a role in the treatment of choriocarcinoma. Now this drug, again, it has to be given intravenously. So there could be severe injury on extravasation. Other than that, it causes GI related side effects like nausea and vomiting. And sometimes in some of the patients, there could be erythema and inflammation of the skin. Now coming to the other drugs which inhibit topoisomerase 2 and intercalate DNA. So these drugs are in this group like daunorubicin, which is mainly used in acute myelogenous and acute lymphocytic leukemia. One important feature of daunorubicin is it imparts a red color to the urine, but the most important and long-term side effect being cardiotoxicity. So it can this cardiotoxicity, it can even produce certain changes in the ECG, like T waves and ST segment also. So it can lead to arrhythmias and also congestive heart failure and the syndrome known as pericarditis and myocarditis syndrome. Some patients that could also be alopecia. The other drug is doxorubicin. So this can be used in various types of sarcomas, lymphomas, and breast cancer, thyroid cancer, stomach cancer, and neuroblastoma. So again, this drug also causes main side effect being cardiotoxicity. So when we have to administer these cardiotoxic anti-cancer drugs, what we can do is we can also priorly administer dextrazoxone, which is an iron chelating agent, which may be responsible for the lipid proliferation in cardiac tissues. So this can be used, dextrazoxone can be used to prevent the cardiotoxic effects. Drugs of diverse mechanism of action. So there are drugs like bleomycin, mitomycin, L-asparginase, retinoids like tretinoin, and arsenic dioxide. So bleomycin mainly binds to DNA and it generates free radicals. So main use is in treatment of lymphomas, testicular cancer, and local treatment of bladder cancer. This drug is also a part of the ABVD regimen. So the main routes of drug administration are intravenous, intramuscular, or subcutaneous administration. We need to reduce the dose in patients with renal dysfunction, And most important and serious effect is pulmonary toxicity. It can also cause erythema and ulcerations in some of the patients. Asparagines is mainly used in acute lymphocytic leukemia treatment, and again it can be either administered intravenous or IM administration. So hypersensitivity reactions, sometimes even anaphylaxis can be produced, hyperglycemia and clotting abnormalities. Next drug is hydroxyurea, which is mainly used in the treatment of chronic myelogenous leukemia, polycythemia vera, and sickle cell disease in adults. So this has to be administered orally, and again, reduce the dose in patients with renal dysfunction. Arsenic trioxide, mainly it is used in treatment of acute leukemia. So this can be administered orally or intravenous administration. There is a syndrome known as leukocyte maturation syndrome, which can occur with arsenic trioxide also. So there could be some symptoms such as pulmonary uh, pulmonary fibrosis, or even mental state changes also can occur. But a serious and rare side effect being Torsades de pointus, wherein there is QT prolongation and occurrence of ventricular arrhythmias. And the other drug in this group is tretinoin. So again, this drug also is used in treatment of acute myelocytic leukemia, and this drug can be administered orally. So this again leads to leukocyte maturation syndrome, which consists of occurrence of pulmonary distress, pulmonary effusion, there could be fever and even dyspnea. Hypercalcemia and renal failure are rare side effects of retinol. Then we have the nitrogen mustards like meclorethamine, which is used in the treatment of Hodgkin's lymphoma. So important side effect being vascular damage during injection because of its vesicant properties. The other important and commonly prescribed drug under this group is cyclophosphamide. So it has a wide various types of indications like acute and chronic leukemias, lymphomas, multiple myeloma, and even autoimmune disease conditions such as rheumatoid arthritis, nephrotic syndrome, and vaginous granulomatosis. So either it can be given orally or intravenously. The important adverse effect being nephrotoxicity and mainly because of urotoxic metabolite known as acrolein. So there is severe hemorrhagic cystitis when we use cyclophosphamide in high doses. So this can be prevented by giving mesna. And also we need to provide vigorous hydration when high dose treatment is being given. Next drug is ifosfamide. So mainly used in sarcomas, both pediatric as well as adult, and germ cell testicular tumors. So this drug can also cause neurotoxicity and even seizures in some of the patients. So methylene blue treatment is possibly useful. The other drugs being chlorambucil, which is given orally, and the indication being chronic lymphocytic leukemia. Busulfan is belongs to the alkyl sulfonate group. So it is used in treatment of chronic myelogenous leukemia, high dose regimen with bone marrow transplantation. So this can be given orally, but major adverse effect is it causes pulmonary fibrosis, and there could also be occurrence of seizures, suppression of the stem cells. Other drugs like carmustine and streptozotocin. So carmustine can be used in the treatment of lymphomas, malignant gliomas. So again, vascular damage can occur during injection, and there could be even delayed myelosuppression. The next the next drug is streptozotocin, which is useful in the treatment of insulinoma and carcinoma. But there could be renal toxicity, even sometimes renal failure. All this time, I have discussed some of the existing and frequently prescribed anti-cancer drugs. Now, from this slide onwards, I will be discussing about all the various new targets which have been discovered. So the first and foremost group is tyrosine kinase inhibitors. So we have drugs like erlotinib, gefitinib, afatinib, and osimertinib. These are the drugs which come under this group. So under this group again, the EGFR inhibitors, erlotinib, which is mainly used in advanced cases of non-small cell lung cancer with mutant EGFR, and also advanced pancreatic cancer in combination with gemcitabine. So the main adverse effects which it can cause: skin rashes, stomatitis, interstitial lung disease, and it is also a cytochrome 3A4 substrate. So we should be aware of all the drug interactions, either because of enzyme induction or enzyme inhibition. And two points to be noted is anticoagulant effect of warfarin will be increased, and concurrent use of proton pump inhibitors will reduce the bioavailability and absorption of this drug. The other drug in this group is gefitinib, mainly used in advanced, again, non-small cell lung cancer. Side effects are similar to erlotinib, but it is not the bioavailability is not affected by the presence of proton pump inhibitors. The other drug is afatinib, which is an irreversible inhibitor of EGFR, that is endothelial growth factor receptor, or hormone receptor 2. So this can also be used in non-small cell lung cancers, squamous cell carcinoma of the lung. Side effects, it can cause hepatotoxicity, and we need to reduce the dose in patients who are having renal insufficiency. Osimertinib, also the indications are somewhat similar to the other drugs in this group, and the side effects being less intense compared to the other drugs in this group. But this drug, rarely it can increase the QTC interval and cause ventricular arrhythmias. Next, coming to the EGFR inhibitors. So growth factor receptor inhibitors, which includes EGFR inhibitors, drugs like cetuximab, erlotinib, and afatinib. VEGF, vascular endothelial growth factor inhibitors, bevacizumab, sorafenib, sunitinib, and pazopanib. So sunitinib, it is used in metastatic renal cell carcinoma and gastrointestinal stromal tumors. If there is, and if also in pancreatic tumors. So again, the adverse effects like bleeding, hypertension, proteinuria, thromboembolism, all this can occur. And some of the patients also experience fatigue. There could be chances of hypothyroidism, and other common adverse effects being bone marrow suppression and diarrhea, and less common being congestive cardiac failure. But because it causes, in some of the patients, hypertension, proteinuria, and other side effects, we need to monitor the blood pressure and blood counts, thyroid functions at regular intervals. Then the other drug in this group is sorafenib. So this drug can be used in treatment of hepatocellular carcinoma, metastatic renal cell carcinoma. Adverse effects somewhat similar to sunitinib, but more commonly it will produce GI-related adverse effects and fatigue, and less common being cardiomyopathy, bone marrow suppression. Axitinib is another drug which is used in the treatment of advanced renal cell cancers. So this drug again, it can cause hypertension, thrombotic and hemorrhagic, even sometimes even chair perforation. Next, we have the group VEGFR inhibitors. So important drug is, or the prototype drug in this group is lenvatinib. So it is used in the treatment of recurrent or metastatic thyroid cancer. Other indication being renal cell carcinoma, endometrial cancers also. So side effects, uh, again, like the other drugs in this category, it can cause hypertension, thrombotic hemorrhagic events, and in addition, even hepatotoxicity, QT prolongation, and it is a substrate for cytochrome 3A4. Now we'll come to the inhibitors of BCR-ABL and platelet-derived growth factor receptor and KIT, that is kinase inhibitors. So in this category, or I can say amongst all the tyrosine kinase inhibitors, imatinib was the first drug which was discovered and introduced mainly for treatment of chronic myeloid leukemia, melanoma, and gastrointestinal stromal tumors, and even chronic leukemia. So the adverse effect mainly it is related to the GI tract. So it can cause nausea, vomiting, diarrhea, fluid retention, and edema. Asatinib, so it can be used in treatment of CML, which is resistant to imatinib. And adverse effects are again similar to imatinib, but this has more chances of causing even pleural effusion, heterotoxicity, and the absorption and hence the bioavailability of dasatinib is reduced after treatment with antacids or H2 blockers. So the other drug is bosutinib. So again, this is used in treatment of CML. So similar side effects like diarrhea, nausea, thrombocytopenia, and sometimes even rashes. Next group of drugs are the inhibitors of RAS and inhibitors of JAK. So important drug in this group is ruxolitinib, used in treatment of myelofibrosis and polycythemia vera. So important side effects being anemia, thrombocytopenia, and sometimes it can even lead to basal cell carcinoma. And we need to reduce the dose in renal or hepatic impairment. Next group of drugs are the modulators of protein degradation. So drugs like thalidomide, lenalidomide, and bortezomib. So when we think of thalidomide, so what do we actually remember? The thalidomide disaster, isn't it? So thalidomide disaster mainly it occurred when the pregnant women were given administered thalidomide for treating morning sickness, but it led to one of the teratogenic effects known as fecomelia or uh, what is known as seal lips. So the offsprings were born with cleft lip, cleft palate, and other congenital anomalies. Hence, it is contraindicated or we cannot use it in pregnant women. And most serious adverse effect of this drug is sensory neuropathy. And also patients with pre-existing neuropathy are at higher risk. And as I have just discussed that it is highly teratogenic and it may cause sedation in some of the patients. So concurrent administration of CNS depressant should not be done. The other analog or drug in this group is lenalidomide, mainly used in the treatment of multiple myeloma and CLL. So it can lead to bone marrow suppression, leukopenia, and what is known as tumor lysis syndrome in some of the patients. So there could be tumor flare, lymph node swelling also. So we need to start with lower doses in patients with CLL. And one more important feature is it downregulates CD20, which is the target for monoclonal antibody therapy. And in comparison to thalidomide, less amount of neuropathies or sedation. However, we have to reduce the dose in patients with renal dysfunction, and also it is not having teratogenic potential. The next drug being proteasome inhibitors, drugs such as bortezomib. So it is used in treatment of multiple myeloma and mantle cell lymphoma. The major side effects being thrombocytopenia, peripheral neuropathy, and rarely it will cause congestive heart failure. And again, we have to keep in mind about the drug interactions because it is metabolized by cytochrome 3A4. Next class of drugs, it is the cytokines which stimulate the immune responses, mainly the drug known as aldesleukin, interleukin 2 stimulant drug it is. So it helps in increasing the cytotoxic killing and also apoptosis. And main side effects being again what is known as capillary leak syndrome. So it consists of hypotension, and sometimes there could be pulmonary fibrosis and other features which are rarely occurring, but it is reversible if we discontinue this drug. Then we have drugs which target cancer cell surface molecules to engage the immune cells. So mainly the drug in this group is rituximab. So it is mainly used in the treatment of non-Hodgkin's lymphoma, CLL, and certain other autoimmune diseases also, including multiple sclerosis. So here the infusion-related toxic effects such as fever, rashes, and dyspnea can occur, and also risk of hypersensitivity reaction. So we need to increase, use slow increase in infusion rate, and then risk of tumor lysis syndrome also is seen with some of the patients. And another feature of this drug is there could be reactivation of hepatitis B virus also. Now, the most important therapy, which is known as cellular therapy. So, the CAR cell therapy, which is nothing but chimeric antigen receptor T cell therapy. So, as of now, 5 CAR cell therapies have been approved by FDA, and mainly it is used in the treatment of patients with ALL who are refractory or any relapse cases. So most common adverse effect is cytokine release syndrome. So it is characterized by clinical features like fever, headache, uh, hypotension, dyspnea, and sometimes there could be life-threatening neurological toxicities also. Now, how do we treat this cytokine release syndrome? With by the drug known as tocilizumab, and this has been approved for treatment of CAR cell-induced this kind of cytokine release syndrome, and in combination with corticosteroids also we can prescribe. Then, of course, another important group of drugs are the hormones, hormone receptor antagonists, agonists, and related agents. So it consists of the GnRH agonist, antagonist, and SERMs, SERDs, aromatase inhibitors. Coming to the first group, that is GnRH antagonists, mainly cetrorelix and relugolix. So treatment of all forms of advanced prostate cancer, and this drug cetrorelix is not very commonly used because of the high cost and also more frequent injections. So what is the important side effects? It will, if relugolix is given orally, it can cause prolonged QT interval, but it is rare, and few cardiovascular events also. But a major thing or point is drug interactions can occur because it interacts with P-glycoprotein and cytochrome 3A4. So if we administer concurrently any of the enzyme inducers like rifampicin or erythromycin, which is a P-glycoprotein inhibitor, it can lead to drug interaction. Then the GnRH agonists, mainly leuprolide and goserelin. So these drugs are used in both pre and perimenopausal women and with anti-estrogens as an adjuvant therapy for any kind of metastatic disease. So important adverse effects being vasomotor symptoms, there could be decrease in libido, osteoporosis, vaginal dryness, and drug interactions are not frequent with this drug. Then next drug is SERMs, so selective estrogen receptor modulators. Important drug in this group is tamoxifen. So mainly used as an adjuvant for pre and postmenopausal women with hormone receptor positive breast cancer. Also treatment of advanced and metastatic breast cancers in both pre and postmenopausal women. Some major toxicities because of estrogen receptor agonism, it can cause endometrial carcinoma, sometimes thromboembolic events, and vasomotor symptoms, menstrual irregularities. So one more side effect, it can cause cataract. And again, this with the administration of this drug, we need to keep in mind about various drug interactions. Uh, Torimifene is another type of SERM which is used in metastatic breast cancer in postmenopausal women. And this drug also has, it can cause various drug interactions. So we need to use with uh, caution in some of the combination therapy. And rare side effect being prolongation of QT interval and what is known as Torsades de pointes, that is ventricular arrhythmias can occur. The next drug is fulvestrant, which is nothing but selective estrogen receptor down regulator. So this drug is very helpful in the treatment of advanced or metastatic breast cancers in postmenopausal women. So this fulvestrant, it binds to the estrogen receptors and blocks estrogen actions. So IM loading monthly dosing is preferred, and steady state concentration will be achieved in the first month. So what are the important adverse effects? So injection site reaction, back pain, bone pain, fatigue, and sometimes even vasomotor symptoms. Next class of drug, very important, aromatase inhibitors. So drugs like anastrozole, letrozole, which are non-steroidal competitive inhibitors, while exemestane is a steroidal irreversible inhibitor. So main indications are treatment of adjuvant treatment of postmenopausal women with in conjunction with what is known as ovarian function OFS, that is ovarian function suppression. So also it is used in the treatment of postmenopausal women with metastatic or advanced breast cancer. Um, and sometimes even in breast cancer prevention in postmenopausal women. So this drug is contraindicated in premenopausal women with intact ovarian function. Some of the major side effects which these drugs can cause is vasomotor symptoms, arthralgia, osteoporosis, vaginal dryness. So again, drug interactions should be kept in mind whenever we, if at all concomitant use with tamoxifen is required, it will reduce the plasma levels of anastrozole. And similarly, with other cytochrome 3A4 users, it should not be given. So finally, we also have the role of glucocorticoid receptor agonists such as dexamethasone, prednisolone, and other drugs, mainly used in the treatment of malignant disorders, hematologic disorders. It also helps in symptom palliation in various cancer types. So because of its some amount of antiemetic action, it is actually used as an adjuvant drug in case of MSS. It also reduces edema, and the major toxicities we already know. These drugs can cause Cushing syndrome, glucose intolerance, osteoporosis, psychosis, and drug interactions also we need to keep in mind. So concomitant use of erythropoietin stimulating agents or estrogens can increase the risk of thromboembolism. Now, finally, we come to the other part which is known as drug repurposing. So, what are the recent advances? So, first, the antiplatelet drugs like aspirin. So, off-label use because of its anti-inflammatory action and antiplatelet action, it can be used in the treatment of colon cancer. And anti-inflammatory drugs such as diclofenac, which is an NSAID. This also is indicated in some of the cancers like colon cancer, rectal cancer, and thiazolidinediones or the oral hypoglycemic agents. They also have some amount of role in the treatment of pancreatic cancers and other uh, types of cancers. And other drugs which have been tried are antihelminthic drugs like albendazole, antipsychotic drugs also, mainly valproic acid and some of the SSRIs. So, what is the role of valproic acid in the treatment of some of the types of cancers? It can cause apoptosis and cell death. It can cause and also improve the uh, vascularity. So, similarly, antiviral drugs and antifungal drugs also have a role in some of the cancers treatment. Finally, artificial intelligence and its role in cancer, target identification, and drug discovery. So, we all know that there is great difficulty in understanding the pathogenesis of cancer because mainly because of the complexity of the disease itself. And therapies tend to have undesired desired effects even on the normal tissues. So, they can cause serious side effects in patients, which we have seen with all the classes of drugs. So, what is the role of this artificial intelligence? So, AI algorithms are of two types. One is known as network-based biology analysis algorithm. The other one is machine learning-based biology analysis algorithm. So, these type of AI models, they have provided with a framework to study the relationship between network statistics and cancer also. So, this can lead to discovery of various novel drug candidates. Now, we should not forget about the role of cancer vaccines. So, these can be of two types. One is known as the preventive cancer vaccines, the other one being therapeutic vaccines. So, to name a few of the preventive cancer vaccines, Cervarix, which is approved for use in infection caused by two strains of HPV, that is 16 and 18. Similarly, Gardasil, which protects against infection by human papillomavirus types 16, 18, 6, and 11. Then we have other vaccines like for hepatitis B. So it is a preventive vaccine which protects against infection by hepatitis B virus. So as I mentioned earlier, therapeutic cancer vaccines are also available. So mainly BCG, which is approved for patients with early stage bladder cancer. So what are the common side effects produced with the approved cancer vaccines? So it can cause anorexia, back pain, fatigue, flu-like syndrome, and other side effects. So which are the vaccine targets under evaluation in clinical trials? So mainly CEA, which is a protein involved in cellular adhesion, cytomegalovirus-related antigens, then of course folate-related proteins, EGFR, and HER2, RAS, which we have already discussed, tumor associated antigens, and telomerase, which is an enzyme that helps to maintain the health of cellular DNA. So, I would like to conclude this talk by saying that the global impact of cancer is extremely negative and the treatment being very, very challenging. And recent advances in the field of molecular biology and deeper comprehension of the molecular pathology has helped in discovery of various new targets. And some of them can also help in total eradication itself of the cancer. These are the references. And I would like to end by these three quotes. Don't lose hope. When the sun goes down, the stars come out, and life is pleasant, death is peaceful. But it is a transition that is very troubled. Thank you for your kind attention. And yes,
Okay, so excellent.
thank you.
Congratulations for nice presentation and very good. I think it was well received by everyone, and I hope you are also happy.
Yes, because it's a
So,
very vast topic, and there
yeah,
are so many new drugs even still under trial and investigation. So
yeah,
I could not cover everything.
yeah. This subject is definitely, like one of the toughest
Yes,
pharmacology, topic.
yes,
And we should visit again and again as many times as possible.
yes,
Then only one will be able to identify. And whenever I try understanding this topic, we will always have some kind of confusion. We'll end up, instead of
Yes.
conclusions, we'll end up with confusion.
Yes.
So I think you made it so nicely, very nicely you explained. As all of us know that, like cancer means it is the, disease where cells, stop dying.
Yes.
That's why, death is the, blessing actually.
Yes.
So in this case, so cells should die or stop multiplying, when it is not required. Okay.
Yes. Yes.
So that is something, especially like, red blood cells, they should keep on multiplying. They should
Yes.
not, they should not stop, but it should be in a proper manner, proper maturation should happen. So like that. And various drugs are staged based on the cell cycle.
Yes.
Okay. So many, nucleotide analogs, which will go and incorporate into the DNA and create a wrong, DNA, and the cells will die, or cells division is arrested in where like tubules are stopped, or like, mitochondria, like which the DNAs are not getting separated, or so like that. So it's a very complex subject, and still research is going on. Very important area of research even today. And it is also, rare diseases also, because every patient can have a unique disease, and it may be because of unique change in their DNA, and sudden mutation that is, which is triggering the development of this cancer. So like this, or oversensitization of a receptor, or undersensitization of a receptor. So it's a like, a lot of concentrated efforts are required to ensure that, like we keep in pace with the development. And also
I forgot to
recent, yeah, tell me.
I forgot to mention about one more modality of treatment for some of the cancers, which is still under trial. Just like how we have the transdermal patch, which can be used locally.
Yeah,
Like that, some chips they are under trials. So
yeah,
it contains the drug
yeah,
molecule, the anti-cancer drug, and it can be just placed locally over the site of the tumor. So
yeah,
it is still being investigated, and still it is under trial.
yeah. So that is the thing. Like that, like we will have, additional, lot of changes. And also there can be, I have seen many, formulations are developed just for targeting the, particular cancer. Maybe, like I would say, esophageal cancer. So in
Yes.
such cases, like patients are not able to swallow the tablets. So they need to, make some solution type of solution, tablet, like drugs, or mouth dissolving tablets they may prepare. Or new formulations are, made just for this kind of diseases. And I would say, for pain reducing, like vomiting is the major problem. So 5-HT antagonists, they play very important role in reducing. Combination therapy is the another area, like continuously, innovations are happening,
Mm.
that also.
Yes.
So I think we exceeded the time that we accepted. So in that way, if there any, I think, there is repurposing. So she mentioned about the, repurposing of SSRIs in the cancer therapy, and again aspirin you mentioned, and
Role of vaccine.
yeah.
Role of vaccines also.
Yeah, vaccines you mentioned. I think, thank you so much. And with this, like, we'll keep inviting more number of experts also. Okay. This is the topic of, interest, and anyone who is interested to speak more on maybe some special, like I have received one article related to biologicals in biologicals, means non-biologicals in cancer, lung cancer, and also non-lung cancer thing. That is also very interesting. So we'll see if I can invite those kind of speakers again. Some more insights we can get. In addition, we can say that we will be organizing more programs. So thank you everyone. I will say that like lot of today I think we reached to more than 100 participants today, and totally 200 plus registrations we just received in 2 days. Where MPS programs are well received. Congratulations, Dr. Sapna, for
Thank you.
conducting this, and very nicely you managed, and you managed everything within the time also. It went very well. So really nice. Looking
Thank
forward
you.
for more programs.
Yes.
Is there any feedback form? Yes, we will be giving you the feedback form, and also there will be certificate issue form will
Yes.
be shared, so that if you give the feedback, automatically you will receive the certificate also. It was. I was just saying that like I would like to tell you that like I request everyone to look into this crucial pharmacology science books, and see if there is a. You are also one of the authors, Mr. Sapna. You also
Yes.
contributed one interesting topic. I think we should talk about that topic sometime next.
Yes.
So that is also. So I was just saying that like a crucial pharmacology trends book and clinical trial management books of MPS. Please do support by encouraging more number of postgraduate students to buy these, and then this is mainly to please help us to reach out to everyone, Medical Pharmacology Society. And if any of you are interested in becoming life members, please do join and connect with me. So we will definitely support you yeah, for so we will support you for growing with the MPS society. And looking forward for more program. Most probably we'll come up with additional in future. We have lined up a good number of webinars. We will also share timely. Most probably material vigilance is coming up, and also antimicrobial stewardship is coming up. And brain, some I think artificial intelligence related topic which we are looking into it. So a brain like a neuro brain something is that I will just
Neurostate.
tell you. Yeah, that is also related to it. And so nice. Thank you so much. So if no further discussion is required, so we can call for the day. So have a good day. Have a nice day ahead. Enjoy your day. Thank you so much.
Thank you. Thank you.
Yeah. Congratulations again.
Thank you.